Cervical spine masses, volume 3 here. So why don't we start, Brian, why don't you take this case? Oops.
Okay, so we have a chest x-ray showing a mass. Slightly increased uptake on PET. There's some, hold on one second. So, yeah, I'm in comments. The mass expands the rib. So this could be, I forgot what section we're in, but an expanse all partially lytic mass, so could be metastasis, could be a,
Okay.
at that location, chondrosarcoma.
Yeah, with this kind of speckled calcification, a little bit of uptake on the bone scan, and here's a CT. And CT is often nice to categorize the calcifications here, which are a little bit nonspecific, but it doesn't really look like an primary ossifying tumor. It really looks more cartilaginous here, I think, with a large soft tissue mass associated with it. And there you can see the characteristic on ultrasound. So this ended up being a low-grade chondrosarcoma. All right, Philip.
So right neck mass. So it's calcified. It's kind of to the right paraspinal. In the right paraspinal area, I'm trying to determine if it's contiguous with any parts of the C-spine or not, and it's kind of hard to tell. Okay, so here we have. It looks like it's arising from the superior facet of the right superior facet. It's almost like an exostosis. So I'd be worried about like a big osteochondroma or a low-grade chondrosarcoma. Okay.
Fatima?
Okay, multiple axial images of the upper thoracic spine demonstrate, I believe, a mass in the right pedicle there. Yeah, it's extradural. Need more images to see. So there it is, peripherally enhancing, and two. Right, it's peripherally enhancing extradural mass. I'm trying to see if it's coming from a particular thing or not. Chondrosarcoma, okay.
Brian. Brian? Are you still there?
Oh, yeah, I was muting myself accidentally. I was talking into the mute. Ring arc calcified matrix on the CT and chest x-ray, and some areas of lobulated hyperintensity with soft tissue mass, and so, yeah.
Sorry. So again, these are just all different kinds of chondroid masses, going from the more benign to the more aggressive type. So at 7% of chondrosarcomas are in the vertebral column, and they tend to like the posterior arches and the thoracic spine. Okay, Philippe.
All right, so this is a kind of a Panorax study demonstrating a large lytic mass in the right mandibular body. So MR, it's kind of heterogeneous, got soft tissue components destroying the cortex, extending into the floor of the mouth, and also the external soft tissues. So there's increased uptake on PET. Oh, not much bony matrix, huh? It's all lytic.
Yeah. Okay. Brian, why don't you take this one? Brian?
Okay. Gait disturbance, dizziness for 2 months. It a small mass that's enhancing. It has a halo of edema around it on the T2s, and I can't tell if that's additional areas of posterior enhancement proximally or that's just kind of artifact. But, oh, and there's, yeah, another one more distal. So metastasis is something I'd be pretty concerned about. Another one there. That'd be my first consideration. So an intracranial mass with metastasis, breast cancer.
So you want to look at the posterior fossa and know the age, right?
Yeah.
So.
And it's downward displacement of the tonsils.
Mixed IM and IDEM.
Oh, okay. So it's same thing?
Yeah, same patient.
Okay. So we have a cystic mass with a peripheral enhancing components, and there's some kind of masses going on in the pancreas. So it looks like a von Hipple Lindau. Yeah.
Hemangioblastoma. Good. Very good. And that's just a summary. Well, let's just go on and look at cases. Okay, Pratima?
Okay, AML recurrence. 43-year-old with AML recurrence. So the arrow is pointing to a mass in the upper anterior cervical canal that extends into the neural foramina there. Looks again extradural. Could be.
So there are more than one mass, right?
Right. There's a couple of them, right? Right. So it could be metastatic. Could it be drop mets? Could be a schwannoma. Could be a nerve sheath tumor. So I'm trying to put this all together. So that looks like an acoustic neuroma there.
So you have at least 3 lesions.
3 lesions, right? So this is NF2, Granulocytic Sarcoma. Okay, I wasn't gonna say that. Yeah.
But I think
Yeah.
about neurofibroma.
Yeah.
Was a good thought.
Right. Okay.
Philip, why don't you take this one?
Okay.
That's next one. So the history of AML was helpful. Okay.
So a 21-year-old rapidly growing mass with tenderness. So this looks like it's kind of a heterogeneously enhanced. So that's heterogeneous enhancement. There's some increased T1 signal within the center of the mass. It's kind of arising from the posterior costochondral junctions or within the musculature actually. It's going through the rib, extending into the pleura. So I think about a Met or.
I won't be showing very many mats.
Yeah. Granulocytic sarcoma. Or
AML history.
okay. There's no bony matrix. Yeah. Not much uptake. Wouldn't you expect that to be really hot on?
It's extra. It's outside the bone.
Oh, so there's.
Yeah. So it's a fairly rare tumor, but not possible. We'll see some other extras. Skeletal Ewing sarcoma. Again, most of these I don't think you could make a specific diagnosis with MR. So that's not really what mostly requires pathology. Let's see. Okay. Did I hear Eric join us? Eric.
Yes, I'm here.
Why don't you take this one?
All right, we got a CT cervical spine. Looks like it's C2. There's a destructive or lytic mass with ill-defined margins, and it's a metastasis.
Yeah, sorry about that. I just told everybody that I wasn't going to show any metastases. I got to do that to mix people up. Okay. I don't know if it's the same case or not. I don't think so. But anyway, Brian, why don't you take this one?
Okay, there's a mass at the base of the dens, expanding, replacing marrow, slightly hyperintense on T2. So to consider, again, I'm and it's subtly lytic on the X-ray, and there's maybe some collapse on the left. Yeah, mets, plasmacytoma, lymphoma.
Pratima?
Okay, big expansile destructive lesion at C2 extending anteriorly. Again, could be mets, plasmacytoma, lymphoma, or any bone tumor. It's a pretty big one. And it's going in the posterior elements as well, causing cord compression or impression upon the posterior aspect of the cord. And yeah, same differential. Acute onset neck pain after trauma. Is this the same case? It does.
No, I don't think so.
Yeah.
That's so some of these are out of order.
Okay.
So, I think this one I think was it was just a sarcoma.
Okay.
Philip, what do you think of this one?
So it looks like it's a path fracture through the pedicle with surrounding marrow edema, and the pedicle looks expansile. So again, you think about a met to the pedicle.
But this is very
Or not.
There's not much enhancement inside the bone, just a lot of enhancement around the soft tissue outside of it.
Okay. It's lytic and expansile.
You've got more of a peripheral rim of calcification, right?
Yeah. Like an osteosarc.
There's also metastasis. Okay. Eric?
Okay, sagittal MRs through the soft tissues of the neck, showing multiple areas of nodularity in the dominant mass, kind of superior aspect. Suspected probably large lymph nodes, so certainly would think about lymphoma, also reactive processes. Could be metastatic adenopathy in the setting of a squamous cell, yeah.
Okay, Brian.
All right, well, we're missing a chunk of posterior elements on the right side, the mid and lower cervical spine. It's obviously lytic, and there's a pathologic fracture through C6, and there is some convexity posteriorly, so be concerned about metastasis and some, compression of the cord there.
Yeah, it looks neoplastic. Doesn't necessarily have to be from metastasis. It could be a primary too.
Sure.
Okay, that was well, I don't have the slide showing the pathology. I apologize. I don't remember what that pathology was. It was probably metastasis. Okay, and that we can. Okay, so why don't we stop the recording here?